Hey everyone, welcome back to the North of Patient podcast, Conversations on Health Beyond Care. If you've been following insightful and intersectional writing on healthcare in the United States in the last 10 to 15 years, it's likely you've come across the work of Kim Bellard. Kim is a former health insurance executive who, amongst many other things, pioneered one of the first online health insurance products in the United States in the 90s, and he went on to become the editor of the infamous Tincture Health, a bold online publication discussing critical conversations around improving healthcare in the United States. Kim's career journey was not traditional by any means. From being a math graduate to a healthcare policy leader, his bold ideas and curiosity led him to propose healthcare reforms at Prudential and Blue Cross Blue Shield, setting the tone for a lifelong career in pursuit of innovation. Our conversation covers everything from life in Cincinnati, including the peculiar decisions that locals seem to make about where they get their healthcare, to exploring the origins of complexity in healthcare delivery in the US, to talking about the incredible potential of the microbiome. North of Patient is available on Spotify, Apple Podcasts, YouTube, and Substack. Subscribe and join us on Substack in exploring the evolving landscape of healthcare. Without further ado, here's episode 11 with Kim Bellard.
I remember when I first moved to Cincinnati, I was at a table of health executive, hospital executives, and so on, and I made a comment about, "Gosh, it's so unusual in this. Most of us are not from Cincinnati," and one of the Cincinnati residents, natives, said, "You don't think that's a coincidence, do you?" They put all the outsiders together, and people forget that in the early 19th century, Cincinnati was like the third largest city in the U.S.
Really?
It was a huge river town when the Ohio River was everything. That was the way you got to the Mississippi. That was the way you could get from the east to the Midwest.
Interesting.
The classic story is that at some point in the 19th century, the railroads were considering whether they make their terminus here or in Chicago. And at that point, Cincinnati was like, well, we're a river town. We don't need railroads. And so Chicago got the railroads, and Chicago became the second and then third largest city. And people in Cincinnati are like, yeah, we're probably okay with that. We'd rather be who we were and be smaller than, be this massive city.
Yeah, well, it's interesting how some of those decisions end up making such a significant impact on the trajectory of the city and therefore the culture of the city as well. From a healthcare perspective, where does Cincinnati rank in terms of American cities and access to healthcare? Anything uniquely different about Cincinnati?
Well, we have several still live competing hospital systems, which is unusual nowadays. It hasn't all become one big system, but there's not really any of the national systems. Well, I guess the Mercies are here. So Bon Secours Mercy is the only real national one here. So they still have a very local hospital system sort of oriented thing, and there's still competition. So that's sort of unusual, but they've fallen into the trends about buying up physicians and so on. What I always remind people about is that, so as you may not know, the Cleveland Clinic is one of the, depending on who you read, two of our best healthcare systems in the country, and if not the world. And people from Cincinnati don't normally travel even to Cleveland, which is just 3 hours up the highway. People, it's a microcosm of America generally. We don't, even if there's a much better place a couple hours away, we'd rather get our care locally, no matter what it is. And I think that's a big problem for America, that we think the local is good and that, our hospitals are just as good as any hospitals everywhere else. Like, well, no, they're not. There's no hospital in Cincinnati that is nationally ranked in anything. And the Cleveland Clinic is nationally ranked in like 15 specialties. Ohio State is nationally ranked in a couple things, but people don't think like that. People want to get their care locally and think that the quality of the care that they get is just fine and is just as good as it could be. And for most things, that's probably true. But, if you're going to have open heart surgery or a liver transplant or something, things like that, it probably does make a difference where you go. And I'm not sure that most people think about that.
And what do you think that stems from?
Well, Americans always think that their doctor is the best and their hospital is the best. And that leads to, what I'm sure we'll get into this, but one of the two biggest problems with American healthcare, and probably with healthcare everywhere, is that for the most part, we don't really know what works, and we don't really know who does things well. And if we can't do those two things, well, we're just really throwing our money away. And that's why we have such expensive healthcare, because we don't know how to spend it. We don't know who to spend it to, spend it with.
Okay. So, you mentioned, for example, that you were working for a health plan and you had some engagements with hospitals. Can you speak a little bit more about your actual career journey and how that started and how you ended up into the very curious and kind of prolific writer that you are today?
I would say my career was not a well thought out strategic move. Interesting things came along and I took them. So I mentioned that I had a funny story. So I was in graduate school in math, and I had deliberately avoided any kind of practical math. I had avoided all business courses. I was in foundations, which is mathematical logic and set theory. So nothing remotely applicable to anything. And when I was in graduate school, I decided I didn't want to be in academia anymore. And so this was in the late 70s, telling you I'm old. That was not a good time to be getting a job. So I went out looking for people. 10 years later, the Wall Street firms would have been recruiting me as a quant. 20 years later, I would have gotten into computer science. But at that time, gosh, I just wanted to hire someone. I wanted someone to hire me. And I fell into getting a job at Prudential Health Insurance as a group underwriter for, life and health stuff. So we're the ones that set premiums for things. So there wasn't anything magic about that. I didn't, that was before contracting and networks and all that kind of stuff. So it's really very basic stuff. But for some reason, about a year into my career, I got it into my head that I had ideas about how to reform the healthcare system. And I had a great guy who was my vice president, and I could have talked to him about it. But instead of talking to him about it, I found the name of, I was at a regional home office, 100,000 miles away from the corporate office. I found the name of a senior vice president in our corporate office, and I wrote him a memo with some of my great ideas about how to change the healthcare system. Now, in most companies, it would have been at best ignored, possibly laughed at, and worse, I would have gotten fired. But this guy not only read my memo, he circulated it to the other leadership teams, and he wrote me a very thoughtful reply back. So that encouraged me, speak up when you have ideas about things, and this thing more broadly than a normal job would do. A couple of years later, I ended up getting transferred to the corporate office doing health policy work. So I got to use the same bigger world.
What was in that memo? Maybe not everything, but what was the gist of it?
I don't remember most of the things, but I remember. So at that time, we were paying charges. This was when health insurance really just said, "Okay, give us your bill, and we'll pay a percentage of that." I think one of my ideas was we should establish what a reasonable level to pay for a hospital is, which at that time was not done. So I don't remember the other ideas, and it was years before people would do things like that. But I was at least thinking about the world and how it could be different. And again, what prompted me to bypass all the chains of command and pick this vice president who I didn't know in the least bit? I do not know. And I give Prudential a lot of credit that it was actually taken seriously. And I can't stress enough how encouraging that was to a young whippersnapper like me.
And what would you say would have been the biggest change that came from that you were able to sort of directly connect to?
The biggest change was that the Prudential at that time had what was called a health policy unit, whose job, there was Ivor Tower thing, thinking about broader health policy issues. Well, a couple of years later, when an opening in that position came along, they thought of this lowly underwriter in Chicago and brought me on. When again, there were a lot of people that were closer, a lot of people that were more qualified, and gave me a chance. And so I got a chance to see the bigger part of the corporation, to go to a lot of conferences, a lot of meetings, and so on, to get a bigger idea of the world. So that opened the door to me to this other world. I always kid people about it. In my Prudential career, so I had a bunch of different jobs at Prudential, and I won't bore you through all the walks of it, but I always felt I never had a job that I was actually trained for or qualified for. These things would come along and people would give me a chance to do something. And a lot of the jobs ended up being created for me to do. So people I don't know what to do with him. We don't have the right place for him. So I'll just make up a job and he'll figure it out. And that's what I did. And that was fun. I got to start new things and do new things and do things that people hadn't done before. So whether it's a blessing or a curse, I like to do new things, and they gave me a chance to do new things. So that was kind of intriguing. But as a result, I never really knew what I was doing. And, I was faking it the whole time.
Yeah. That's always the case, right? I feel like that's true for everyone, even when you have a specific title. I know, obviously, my background kind of as a physician, even once you finish medical school and you're practicing, you still feel like you're faking it, right? I feel like that never goes away.
Imposter syndrome, yeah.
Imposter syndrome is a real thing. And for context, I guess, for people who are listening who aren't familiar with Prudential, This is like one of the big health insurance companies in the United States. Is that correct?
Well, it was. In the late 90s, Prudential was deciding to go public, and they sold their health insurance business off to Aetna. So Prudential Healthcare no longer exists, but at the time, it was one of the 2 or 3 largest health insurers in the country.
Okay. And so you mentioned, you've had your time at Prudential, and then what came next? What was the step after that?
Next, I got recruited to go to the Blue Cross Blue Shield plan in Western Pennsylvania, which is now called Highmark Blue Cross Blue Shield. So it was at that time, it primarily did Western Pennsylvania, and oddly enough, the Blue Shield in Central Pennsylvania, but not the Blue Cross in Pennsylvania. And I won't bore your listeners with the intricacies of the Blue Cross Blue Shield system, which make no sense to anybody outside the Blue Cross system. They recruited me to do, again, something else weird. So the executive vice president had it in his mind that he wanted to do a mass customization health insurance product. So if you don't know what mass customization is, think about like when you buy a computer. You say, I want to buy this much processing speed, this much memory, and so on. So you get to pick and choose your elements. I don't know where he got the idea, but he wanted to do it for health insurance. So they didn't have any idea what that would look like. So they said, you figure it out. So I came there, I assembled a small team, we learned about mass customization. And mass customization really runs against everything that actuaries feel about health insurance, because when you give consumers choice, they will select against you. So what's called adverse selection, people will choose the things that they will use and not want to pay for them. So that's what drives health insurance rates up when you have adverse selection. So we had to figure out a way to give people choices without making adverse selection too bad. Anyway, so as we were trying to figure out this product, what it would look like, we had this idea of a product, and it was just terribly complicated. And I happened to be reading an article about, so this was 1999. I read an article about how Bank One at the time was going to open up an entirely online bank, which again, at that time was groundbreaking. And so the light bulb went off in my head and said, like, let's just make this product fully online. Again, 1999, nobody else in health insurance was even putting things online. Make a product that only worked online, inconceivable. But fortunately, my boss and his boss said, okay, Highmark wants to make a statement. Let's do it. So we invested much money, and we got the first fully online product. And to do that, we had to build not just a product, but we had to build a member portal, employer portal, and that created our web presence. And once we started that ball rolling, they went off from there. So we had to get more tools for members. We started doing price transparency, and it led to the whole online web stuff. And at that time, Highmark was not the plan you would have picked to do something like that. Pittsburgh was a very union-driven city, first dollar coverage. The unions don't want to change things. Nobody wants to change things. So we were constantly fighting uphill on every aspect of it. But, my little band of warriors, we kept creating stuff. Things were working, people started using them. And, it just started working. They're still doing that kind of work. And we were one of the first in the country to do it. And again, Highmark got national recognition for it. I was on a conference circuit all the time. So that got me interested in digital healthcare and doing things online. And I've never looked back from that. But it was, again, that wasn't what they brought me there to do. It was just sort of like an unexpected outcome about, okay, how do we make this thing work? And what are the consequences of that? And we just ran with it.
Wow. And so this would have been in the 90s?
It started in 99. We launched the product in 2000, and then I was there till 2008. And we had developed the web way past all recognition of that, and had developed a lot of very powerful capabilities and so on. So it was a fun time. And then my wife decided she wanted to not be in Pittsburgh anymore. So we then moved to Columbus, and I was the trailing spouse in that case. So I started doing some consulting, and then a couple years after that, started doing writing. And eventually that led me to the thing that you're aware of on Tincture, where they first started promoting me as a writer and then brought me on as an editor as well. So I did that for a few years. And
yeah. So for people who aren't familiar with Tincture, because as I understand, Tincture is no longer active, what was Tincture and how did you get involved?
So Tincture it's a Medium publication, and it was founded by a guy named Jordan Schlane, who is he's a physician who now runs a concierge practice. Is quite successful, but he had previously been an e-health guy. He had a health information company that he founded that gave feedback to hospitals about how their patients was doing. His famous saying was, "No news isn't good news. It's just no news." So he did feedback mechanisms so that every day they would send a text or an email to patients saying, "How are you doing?" which then got back and they could do feedback loops. So again, back when he started it, it was revolutionary. Now it's not so unusual, but back
Yeah.
then,
What was the name of that company out of curiosity?
Health Loop.
Health Loop.
Yeah,
Okay,
I
interesting.
forget who bought them, but he made a few million off of it.
Yeah.
When the concert, he decided he wanted Tincture to be sort of a not dissimilar to what you're trying to do with the podcast, sort of avant-garde ideas, different ideas, creative
Mhm.
thinkers, and so on. He spotted somewhere, I don't know where he saw my writing, but he said, why don't you write for Tincture and submit that. And after a couple of years, the guy who had been the editor was going to do something else, and so he said, you're really in the spirit of this. I like your feel. And, so he brought me on to be the editor as well. So we had a bunch of different writers. That's how I know Xenia for the first part, and a bunch of different people. It was always fun to see the different points of view. And I got to, meet, if you can call it that, online, all these different thinkers, and that continue to do my own writing. Eventually, he didn't want to spend the money on it because his capital was going other places. So I think it was 2019, just before the pandemic, that we decided to stop it. And it's now late and lamented, as Matthew Holt likes to say. I continue to publish on Medium, as you may see.
Yeah. Yeah, and we'll talk about that for sure because I find your writing inspiring, and I have actually questions to ask you because I feel like you're one of the few people who thinks both with curiosity and with a critical sense to problems outside of healthcare as well. So I do really feel like being able to understand systems outside of specific silos can be hugely helpful in just helping break things down and get to kind of root causes of different problems. But so Tincture was your first job where you were job as a writer, as an editor, I guess, there specifically. What did you learn through that? And what did you feel like connected most with people in the context of what you were writing?
Let me break that question too. I think the thing I learned most was just getting to meet the writers. There were so many influential and thoughtful writers that I would have not been exposed to otherwise. I might have been able to read their things, but not to interact with them. So that was fun. And we did a series of interviews with healthcare leaders called the 5Qs. So we had 5 questions for various people. So we got to do a lot of those. And again, Tincture had a well-deserved reputation, punched above its weight. And so the people that submitted stories to it were good people to know, and they got to know me a little bit. So that was just a good entree into the world I wouldn't have otherwise have seen. In terms of, what my niche seemed to be, and Jordan would always talk about this, is, as you said, I like to look at non-healthcare stuff and say, why not? Why not healthcare? So I read the Wall Street Journal and see what companies are doing and say, like, well, why doesn't healthcare do things like that? Like, I've long been fascinated with the gaming industry. I'm not a gamer by any means, but when I read about all the stuff they're doing, it's like, why isn't healthcare doing stuff like this? Why don't we have something like Minecraft? Why don't we have something like what's the kid Roblox?
Roblox.
Yeah. So there's stuff like that people in healthcare would not normally think of. So my goal is to try to make them think about it, like what would it look like. So this, like this is what they're doing now. What are some of the lessons that healthcare should be thinking about that? Lego. I wrote an article about Lego. Like Lego doesn't have any healthcare connection, but well, yes, it does. There was a professor in North Carolina that wrote a great book about subtraction, less is more. Like, if you think about design, the tendency is always to add features. So where are the designers that are taking away features? So I'm like, okay, where are the people in healthcare whose job it is to like, what don't we need to do? So what can we take away? So that challenging like that. There was a health system in Hawaii that I profiled. A great story about this doctor formed this committee that was basically said, let's stop doing stupid stuff. So they asked people for suggestions about what are the things that we're doing that we don't need to be doing, and that they've had this official thing.
There was a committee for that,
right?
There was a committee just for that.
Yeah, and so they encourage people to submit these things, and then they implemented a lot of these ideas. And then, as you might guess, a lot of the ideas weren't from the doctors; they were from the nurses and the frontline people. Like, why am I filling out all this stuff? Nobody ever looks at it, and that kind of thing. So, healthcare does a lot of stupid stuff, and everybody thinks they're doing their job. Everybody thinks they're trying to help, but people should stop and think like, so why are we doing this? Why? Again, I don't know what it's like in Canada, but why do you fill out this paper form every time you go to the doctor, even if you pre-register? Who's looking at these forms? I don't know about you, but my handwriting is terrible. Like nobody's reading this form I'm filling out. Nobody's going to do anything with that. Why am I wasting my time filling it out? Like it's the bane of everybody's existence. Like people just need to stop and say, like, is this really helping patients? Is this going to make
Yeah.
patients better? And if it's not, who are we doing it for? Most of American healthcare is about how do we help somebody get paid? And that's the problem, that it's not about the health of the patient. It's not about the patient at all. It's about the revenue to the organization.
Yeah, that's a really interesting way to put it. I haven't heard it specifically like that, but obviously it makes sense, right? It's such a like behemoth of an entity, right? And there's so many moving parts, almost this like, this metastatic creature that just needs the blood to keep flowing in order to sort of remain alive, and doesn't really know exactly what its purpose is. But I kind of make so to make the comparison to the Canadian healthcare system, you certainly don't feel like the system is necessarily working for the purpose of generating revenue, especially given it's primarily a kind of a centrally governed sort of public healthcare system from that context. Although obviously everything is delivered privately, if you will. But the one thing that I do find in Canadian healthcare that's a significant feature, and that I experienced sort of spending 10 years selling, next generation EMR product door to door to clinician offices, was everyone's just always felt like they're in survival mode. Like there was not like one extra breath available to do something beyond what was being done. And as a result, you like the idea of entertaining any type of change, even if that change was very clearly in the interest of the survival of that organization, it would be met with so much resistance. Just because I think everyone just felt like they were just at the very edge of doing what they were doing. And to give you that paper example, 100%, everything here is still, for the large part, obviously there's little changes in pockets in urban areas, but generally speaking, people are filling out forms relating to their intake. That happens even at one of the clinics I work at, which is in downtown Toronto. New patient comes in, sitting in the waiting room on their phone, yet they're completing a paper form, even when the system that they're using has a digital questionnaire system that allows them to capture that. But the staff refuse to acknowledge that that could be a viable thing for everyone, right? And there's all kinds of barriers. It's not to what any individual person. It's this almost this ingrained sense of the fact that there's such fear about doing wrong as a result of that change that no one wants to be the person
Yeah.
that kind of took that last piece of the Jenga tower out, the wrong one, if you will, that toppled everything over, because there's a fear that things are just barely holding themselves together, and that horrible, harm to patient may arise from the result of the fact that they try to change something. So yeah, I do, as much as people are kind of taboo in talking about that, sometimes I do feel like there's an inherent culture that ends up that resisting change.
I use the example. This is probably not a great example in today's age, but so all these digital health companies are coming along.
Mhm.
They're not, to my mind, they're not trying to really change healthcare. What they want is their piece of the pie. And I say, like, so when Uber came along, Uber didn't say, let's improve the taxi industry's, efficiency. They're like, let's wreck the taxi industry. And you need to look for people that would do that with the healthcare system. Like, let's wreck the healthcare system. Let's do something completely different. But everybody is so afraid that if we make too many changes, it's going to destroy people's health and so on. So people only want to do incremental changes and, really just figure out how they get some portion of that $4 trillion or whatever the number is. The sad thing is, though, I don't know of really any healthcare system in the world that doesn't have some sort of these troubles. And it all goes back to what we're talking about at the beginning. Like, no matter how you finance it, we still don't really know what we're paying for and how to pay for it. I was on a podcast last week, and we were talking about predeterminations and denials and all that stuff. I said, the problem is that, okay, let's say that there are 5% of doctors that are flat out incompetent. And let's say there are 5% of doctors that, are overly greedy, they're doing whatever. So that's 10%. And really, if you went into a hospital, you could get people to tell you who those people are.
Yes.
Instead of working to get those people out and making life better for the other 90%, we're imposing the things on 100% of the doctors that's trying to catch that 10% that we really don't want.
Yep.
Again, medical boards, I'm sorry to say it, they're not boards for the patients. They're guilds for the physicians. So their job is to protect the role of physicians.
Yeah.
And that's terrible. So until we can change that mindset, malpractice, you probably seen the studies.
Yeah.
Malpractice, doesn't compensate most people who are victims of malpractice, and B, the ones it does it vastly different. Some people it gives way too much to, and most people it gives way too little for. But there's not a mechanism for really rooting out mistakes or correcting mistakes, because it incents people to try to hide mistakes instead of identifying them and fixing them. So again, the whole mindset is just wrong.
100%. And, and this is something that I spoke with Zaina about when she was on the podcast. And as Zaina says it as it is. And, she kind of called out the fact that the reality is like a lot of medical professionals and not true of just physicians, but of course, physicians are emblematic of this, are culturally a barrier to transformation. And not, again, because of the fault of any individual person. People have good intentions doing what they're doing, but the organization, the profession as a whole is interested, as a profession would, in the self-preservation of the profession, right? And as a result of that, and especially when there is something that has such a significant kind of historical presence as well, that abuts directly with this idea of let's really just get down to brass tacks and see what we need people to be doing. And you see that friction. And I feel like so much of medical training still, and I still participate in kind of teaching and involved with a couple academic organizations in Canada, primarily just to keep that curiosity alive of what's happening in those environments. And, while there's often a lot of lip service to this idea of like innovative thinking and wanting to change things, the core idea is still very much fixated on this idea of the physician kind of owning the health journey. And and I think you describe it really well in the context of this idea of guilt, right? It is, you're ultimately coming into a profession where there's an idea of what it is you're supposed to be doing, and everything else is based on the fixed idea that this must continue to be the way it is.
Well, two things at that point. So do you know the average length of time it takes for new research findings to make its way into clinical practice?
A decade.
20 years.
20 years. Oh, wow.
Physicians like to talk about medicine as a science. And this goes for, have you ever read the Thomas Kuhn's The Structure of Scientific Revolutions?
I haven't read that one now.
So it's a classic book, dated many years of it. He talks about like Copernicus and all that stuff. And it postures science that, science goes along and there's a new finding and then everything's overturned.
Yeah.
But other scientists said, that's not really what happens. What really happens is new findings come along, but they don't take root until the old scientists die off.
Yeah,
right?
yeah, I've heard that.
You need the old guard to go out, and the new people. This is what's happening with EHRs. The older doctors kicking and screaming. The younger doctors, of course we'll type. What else would we do? So that's kind of what we do. But unless you can get more of these new ideas into their hands in the training part and the early things, it's harder to do. Their mentors are these older doctors that want to keep doing things the way they did them for the most part.
Yeah.
One constant refrain I have in a lot of my writing is our healthcare. So it's 2024. Our healthcare system. We want a healthcare system that should look more familiar to a doctor from the 21st century than it does to a doctor from the 20th century. And right now, our healthcare system would look pretty familiar to doctors in the 20th century, and not at all. No, I hope not at all to a 21st century.
Totally agree.
But we need to be thinking about like, would somebody from the future look at this and say, "Oh yeah, that's on the right track"? Would they look like, why would they ever do that? Yeah. Are you a Star Trek fan by any chance?
Big time. Yep.
So I think it's Star Trek 4 where Chekhov has hit his head or something.
Yeah.
And the doctor's going to operate on his brain, and McCoy goes, "What are you, barbarians?" And he's got this little device that just fixes whatever. Like, that's what we should have been looking at. Why are you cutting into this guy's head, for God's sake?
Yeah. I mean, and this is probably a good segue to talk a little bit about the hot topic of the decade, if you will. But in terms of this reality, where healthcare still doesn't change until people change and until there's a transfer of power. How does that reconcile with the pace of change that's happening societally with the emergence of generative AI and the advances that we're seeing in artificial intelligence? What are your thoughts about that? I won't hold you to any of your guesses, but how do you think this plays out?
I have two scenarios, one that I fear and one that I hope for. So one way or another, AI is going to be very integrated into healthcare. And I see a future when there are AI doctors, although I'm not sure I really want that to be true. But I mean, it's the doctor part. I'm not sure I want to limit them to being, doctors as we know them. But AI will be making recommendations and decisions and so on, be fully competent and probably better. The other one is that healthcare will do to AI what it does to most things, bog it down, make it more expensive, and so on. So it tends to adopt a change by absorbing it and transforming it into something that fits into the bloated, expensive system that we have now. I look at like genetic medicine. So like, there's a revolution going on with this kind of stuff. And genetic
And
is like, so why are these things multi-million dollars? So we're in an era of synthetic biology and 3D printing, all that kind of stuff. These kind of things should be cheap. Why are doctors in charge of this instead of, geneticists and biologists and so on? So we don't really rethink who the gatekeepers are and who the overseers are in a new way. We seem the same old, the same team lead, but maybe with some different team members, but they need to be brought on to get their revenue portion and so on. I worry that healthcare will strangle it as well. But, I think there is a possibility that, it will not look at all the same. It will not have the same kind of human components that we were. And I laugh about these people. It's like, oh, no, we'll always need that human touch. And I were like, okay, if you have two surgeons, one of them has this really great bedside manner. He's actually a pretty crappy surgeon. His outcomes are terrible. His technique is terrible, whatever. And you have the other surgeon who's not good at all with patients, but great on the operating table.
he's going to save your life.
Who are you going to pick to do your surgery?
Yeah.
That's going to be the kind of decision we're going to have with AI. Do you want the guy that's going to, comfort you, or do you want the guy that's going to make you better? And I think most people will ultimately want the person that's going to make them better.
Yeah.
If AI is going to be allowed to do that, which I have concerns about, I think that's going to be what's going to change. But again, so who's going to start licensing them? Are you going to make them do board certification? Or are you going to make them do medical school? Or are you going to make them do licensure? Like, and if so, they already can pass most licensure exams,
Yeah.
But is the licensing board going to let an AI doctor into their guild? Like, I don't think so. They're like, they can be our tool.
Yeah.
But no, like, okay, but they're a tool, but I want to get paid.
Yeah.
And, so that goes back like, so once AI is up and running, it's pretty cheap to do any instance, to do a diagnosis, whatever. But are they still going to ask $200 to, do an opinion that takes a nanosecond for it to spit out? God, I hope not. Because you just imagine how many of those it can spit out, how much money they could earn for somebody. You need to rethink the revenue streams.
Yeah. Yeah. A lot to unpack there. And, if I was to paraphrase, I guess, your message, it's, optimistically, there's a transformation that takes place, a meaningful transformation of how care is delivered utilizing AI. And I guess pessimistically, if you will, it makes better the existing bloat that exists in the current healthcare system.
Well, again, I said in another podcast. So one of my fears is that all the stupid stuff. I worry that we will make AI make us less aware of the stupid stuff because it does the stupid stuff faster.
Mhm.
It doesn't get rid of the stupid stuff. It just does it behind the scenes at vastly different things.
Yeah.
If we're not using AI to stop doing the stupid stuff, then we're wasting it.
Yeah.
Like, physicians are already doing like appeals letter. Insurers are already doing AI for like predetermination. So they're having a little AI war about, how do we get this claim paid? Like, stop. You're adding AI to the existing system instead of reinventing the system.
Yeah.
We need people who are going to say, okay, AI allows us to do this. Now, how do we do that? Who's going to get paid for that? What's a fair amount to charge for that? There's no structure to bring that in. And if you did, now you're practicing licensed medicine and so on. So it's going to get a mess.
Yeah.
I've already for a while, like, okay, so China's already developing AI doctors in AI hospitals.
Mhm.
So what's to stop you from going on the internet and using that? Like, do you really think the state of Ohio is going to stop a Chinese doctor from giving me a diagnosis? I don't think so. I mean, we can't even stop TikTok, for God's sake.
And I think two areas to me that seem like very probabilistically high chance of this happening in kind of a near term as an extension of what's happening right now. One is kind of virtual care extending into this AI doctor realm, right? Where people already have this kind of sense, okay, well, I may not want to chat, exchange chats to get full answer. Maybe some people might for small things, but if you're trying to get an opinion on what's happening with your lung condition or whatever else, you want to at least have like a video kind of call. And soon you're not even if you assumed that this person was real, you may not even know if who you're talking to is Dr. So-and-so at the Mayo Clinic or just the AI version of them, right? And that possibility is like very near. And to the end user, to the person, it's actually equally palatable, equally human, and arguably one is quite realistically going to have better outcomes. Right?
Right. I don't know the situation with AI, with telehealth is in Canada. So in America, to do an AI visit with a patient, you have to be licensed in the state where he lives. So
Yeah.
that's a big problem for telehealth companies. Another doctor I knew says, why is it, if the doctor is licensed to do what he's doing, where he's doing it, why should it matter where the patient is?
Yeah.
Again, it goes back to the boards want to protect their turf, and getting doctors licensed in a bunch of different states is good for the boards because they get more revenue.
Yeah.
But the doctor's not really practicing someplace else. He's practicing where he's licensed to practice. So why are we doing it? So again, there wasn't a wholesale rethinking of what licensure should be in an era where there's telehealth options, and
Yeah.
there should have been.
Well, it's the same in Canada, although there's talk of kind of Nashville licensure and more flexibility there. Especially, I think some exceptions are being made in areas that are completely devoid of access to care, where people are able to, through certain programs, be in Quebec and see people, let's say, for example, on the East Coast in Canada. We're seeing a little bit of that, but it's still happening in this very kind of guarded sort of mishmash way. But going back to the other area where I see this just really natural extension, and I'm curious to see how this is going to play out because it's almost there. I mean, I can kind of make this happen. I can MacGyver this happen right now, but you know, lots of doctors are using Ambient Scribe. I'm using Ambient Scribe in my own practice, and just makes so much sense. It's such an easy win, and very palatable. I've only had a handful of situations where people have said, "I'm not comfortable with that." For the most part, people are like, "Oh wow, this is cool," and hey, you're looking at me in the eyes, and this feels like you're actually talking to me, right? And not distracted by this other thing. But then the obvious thing is, why is it just listening to and just transcribing? Why isn't it actually kind of giving me the output and predicting the things that I should be thinking about? And I know we're kind of at the precipice of that happening. I haven't yet seen a solution that does both of those things in kind of a profound way. Right now, I can take the recording of that and put it into an alternative system, such as a kind of glass MD or whatever, and be able to kind of get a differential diagnosis. But you can imagine how that becomes just the natural extension of something that's already happening. And then from there, it goes into the whole well, what was the point of you know, me being there in the room to begin with, other than to be empathic and et cetera, et cetera. And that goes back to the point that so many people have made. And I keep quoting Vinod Khosla for this one. He said, the doctors of the future will be trained at the UCLA School of Arts, not the Stanford School of Medicine, right? Because that's where you're going to want the people who are maximally empathic and maximally, expressive.
Two things to that. So first, I was talking about this last week with somebody. So in a world where patient notes, after visit notes are required, I think having the AI transcribe them and so on is great. But again, I don't know how many patients ever read those notes or use those notes. So again, we should be saying, not just have AI do this, but do we really need to do this? What is the goal? What do we want to be true about that visit, documenting that visit, instead of just automatically having them do what we're doing now? Let's rethink what that documentation should look like and what purpose it serves and to whom it serves. So it's another example about AI just making it faster and easier, but it's not really fundamentally changing things. And on the second point about being empathic, I think that there is definitely a role for empathy in the healthcare system. My wife is a former nurse, and nurses are always first at heart. But
100%.
what is not clear to me is that we will pay the kind of salary to the empath kind of people that doctors now expect. And that's going to be a hard transition for them. They want their money. They want the same amount of money. But even though their role is really just to be empathetic, well, we got a lot of empathetic people in our system. We got ministers and social workers and that kind of stuff. They do a great job too, but they don't get paid what doctors get paid.
Yeah. Very true, right? And it kind of goes back down to this idea of breaking down a job into tasks and then figuring out, okay, which tasks are just very logically extensible to AI and which tasks, like for example, performing a physical exam, require a human being to perform those tasks, regardless of forgetting the title. You can train someone to, and again, even things like, let's say, doing a physical exam. It's well understood that the role of the physical exam in the 21st century is very different than what it was, at the beginning of the 20th century. For the most part, there's obviously, if you're in certain environments, and it's different. But generally speaking, in an outpatient setting, the physical exam has a specific role and purpose. And do you need to be a physician to be able to collect that? And what other tools are going to be made available to better be able to interpret what's happening? A la tricorder, that are going to be able to make a more quantitative assessment of what's happening to the patient.
I think about like things like colonoscopies and mammograms, that kind of stuff. If people try to have thoughtful discussions about whether they're really needed, who they're needed for, you cannot have them, because fighting cancer is, the thing, and everybody knows somebody that their life was saved by that. Like, the data on a lot of the screening we do is really not as strong as you would like it to be. So
Yeah.
we can't really have those kind of conversations because everything has become politicized, probably not the right word, but it's very emotional for many people that have gone through this stuff. But at some point, we need to have those. The whole NNT, number needed to treat.
Yep.
So I think if people saw the NNTs of like most drugs, they would be shocked. How many people are on statins?
Yeah.
Last I looked, statins helped like 5% of people that get them. Like, again, it goes back to what I said at the beginning. We don't really know what works. And again, this is the great opportunity for AI. Like, let that AI loose on all the data and figure out what's really working. I always laugh, like, so my wife is one of these people that when she gets a new drug, she reads all the side effects. And like, all the side effects on all the drugs are the same, basically.
Exactly. Once you get to the long enough list.
But there's not really any kind of, frequency or prevalence. And I would say, like, those drug trials, they didn't test all the underlying diagnoses people have, all the other drugs they had. You cannot do that. But with AI, you could track that. They had people recording all the things they've got, all the drugs they're taking, and how they're feeling every day. You could very easily get a database of, all these things. But I don't think anybody's taking that on. And that would be a perfect role for AI if it had the right data.
Yeah, I mean, especially, and I mean, that kind of goes with the whole idea of this digital twin and, being able
I
to.
love the idea of digital twins.
Yeah, being able to test these things and doing like, N of one studies on, your own clone and then figuring out if it's safe to do for you. And, health is like one of our most sacrosanct things, right? Yet we have such a loose and ill-defined process towards being able to effectively, it's trial by fire, right? Try this, see what happens, come back. Hopefully you don't end up in hospital with some side effect of this, and that goes, and that's how we'll know.
I want our EHR to be a digital twin hologram. So you're sitting in there and you've got this digital twin hologram of you that shows all the things you got wrong with you and all the things that have been done to you.
Yeah,
that's the kind of future we should be thinking about. But now that we got the Epic hasn't changed in 40 years.
Yeah. So here's a thought experiment, and I'd love to hear your thoughts about this. But so we kind of know that as it stands right now, at least, and things will change again as months and years go by. But we're facing the future in which we're imagining multiple agents in our lives, multiple different AIs that are working with us, working for us, doing tasks for us. So imagine, there'll be different forms of kind of health agents that know us, that know our heart rate at any given time of day, that know what happens to our biochemistry after we eat certain meals, that are monitoring what's happening in the environment and air kind of pollen levels and environmental levels and how they might individually respond to us and feeding this information to us. And I also imagine, and especially if you think about it from like the capitalist perspective, different organizations will have their, medical expert agents. And I can only imagine that it's going to be a diverse space of different types of options and tools that you have in terms of where you can get expertise from. And I just imagine like, my agent talking to a Cleveland Clinic agent or another organization's agent. And this is like happening in the background. It's almost like API calls like once a day or like once a week or something. They're just exchanging information and then just keeping me updated in terms of things that are happening in the environment. Maybe one is scanning things that are happening in the climate and feeding to another agent and then kind of consolidating and telling me what's happening. But how do you imagine this ecosystem of agents interacting with one another in the context of an individual?
It's a good question. I mean, everyone's talking about it. People are going to have their personal AI. What I worry about is that, one of the things I worry about is that People have proven to be remarkably bad decision makers when it comes to their health and other things. So, we all know that we should eat more healthy, we should get more exercise, we should get more sleep and that kind of stuff. And most of us don't do that. And
Yep.
that's the cause of a lot of our health problems. Even if we have this AI on our shoulder nagging us, will it really make a difference? I don't know. On the one hand, you can look at the prevalence of smoking has dropped, hugely in the last 50 years, and because people kept nagging about it. So that's good. But still, 20% of people smoke, and they know it's not good for them, but they're going to do it. People know that driving at the speed limit is a good idea, but most people speed. People don't don't wear helmets when they're riding motorcycles. So people still make dumb decisions. And is that their right? Maybe. Should we pay for that? We do. Should we? I don't know. Do you want to blame them or not? I don't know.
And
You've probably seen this thing that, only like 20% of our health is attributable to our medical decisions. And yet we view the doctor as the head of our healthcare team.
Yeah.
But that really, something wrong with that picture. Like, I'm not sure who the head of our healthcare team should be. It's probably not the doctor, but I'm not sure who the other candidate would be. Maybe that's the AI. Maybe the AI is the one that pulls
Maybe it's
everything together.
a world that doesn't exist. Right?
If we trust it and if we do it. But again, would the doctors want to be an ancillary player on this healthcare team? Not most doctors I know.
Yeah, it's true. And nor are physicians fundamentally trained in the true understanding of the social determinants of health. I think now it's obviously become a bit of a buzzword and like it's integrated into like lectures, but that's similarly to the fact that I think like I had like a half day lecture, or maybe 2 half day, like 2 1 hour sessions on nutrition, right? As if it's like the it's something that's more of like a footnote in medical school as opposed to something that's probably deeply interacting with everything. Nor did actually, I don't think we ever had any conversations about the microbiome. And mind you, I trained 12 years ago, and a lot of these things are evolving. I think it's one of the things I also find really interesting is how quickly in the medical community, these concepts of lifestyle, nutrition, and behavioral change are, I guess, the way they handle and the way that they're to a certain effect dismissed. Like a lot of times you hear things like, okay, yeah, lifestyle and nutritional changes, yeah, you recommend those things, you make a referral to a dietitian, but it doesn't work. And we know that it's that people aren't going to change. People aren't going to change. They're not interested in changing because that's work. And I tell people this all the time, and they don't do anything. Like it's typically kind of the the prevailing sort of tone that you often hear in those contexts. But one of the things that makes me somewhat optimistic, although there's concerns with this as well, is as AI evolves to better be able to understand who we are and arguably help us better understand ourselves through that process as well. Quite likely, it's going to have a far more sophisticated capability of being able to create positive behavioral change. Although, of course, we already know that it can create negative behavioral change. That's pretty much been the last 10 years in social media. But we could yield that same power towards being able to do the things that human beings to human beings tend not to do a great job with. And there's very few people that can always be, even if it's the best psychotherapist in the world, it's a human being. And one day is going to be an off day, and one day energy levels aren't going to be as great. And one day they're going to have a weird interaction with someone and it's just not going to click. But that's just not how these systems operate. They're on 24/7 and they're only getting more sophisticated. So I think to me, it's literally a matter of time before that kind of tipping point takes place. And we begin to unlock what I hope to be significant improvements that can take place in how we guide people towards their best decisions. Obviously, lots of concerns around guiding people.
And that raises the question about who's going to pay for that. So if the era of social media taught us anything, it's like, we don't want to pay for anything, even if it means that we're going to be the victims of all this stuff. We'd rather do that than pay $5 a month for an ad-free, thing we could control.
Yeah.
Well, having all these moderating forces is good, but I'm not sure what the revenue stream is for that.
Yeah.
And I'm sort of despairing about that, but doing good things should get rewarded. But people are not farsighted in this kind of stuff.
Yeah. But how about what insurers and there's maybe this is my naivety in the context of American healthcare, but would insurers not be well positioned to be incentivized to want to do that, where they
What
might see really costly medications on the other end as the alternatives?
insurers have been doing wellness programs for 20 or 30 years.
Mhm.
The evidence is that it's a complete scam. It's a $6 billion industry that has produced no returns for the employers that have done it. So,
Mhm.
in theory, yes, they should do it. But again, I'm not sure we've got a model to date
Mhm.
that actually produces the savings.
Mhm.
The savings always go to reducing emergency rooms, that kind of stuff. And
Yeah.
everybody uses the same savings for every program that they do, but people still go to the emergency room.
Yeah.
I don't know. You mentioned something that I want to not lose, but you mentioned the microbiome, and you and I talked previously. That is one of my big fascinations, and I think that medicine is going to have a revolution once we incorporate that. But again, I'm not sure that physicians are the one that should be leading that revolution. Again, should it be a biologist or someone else? But the whole idea about how do we live in balance with the stuff in us, around us, in our environment could be huge. But again, I'm not sure who the right people for that is, and I'm not sure what the revenue structure for that is. But it's going to be a revolution. But I'm not sure how to bring that about or what that's going to look like when we get to it. But
Yeah.
it's going to be different.
I totally agree with you. I think it's a very nascent area right now, and I feel like we're going to look back at the sort of decisions that we've been making, particularly as a healthcare system today, with such an interesting perspective when we realize the impacts, the net impacts it was having, like haphazard. A lot of times it is like antibiotic overprescription. That's obviously one of the most direct examples. You do it so that the person goes out the door because they want a prescription for an antibiotic, and it's too hard to fight them off with that. So you get the prescription, and then who knows what downstream impact that's having on a person. We really don't know. It is fundamentally changing kind of their gut flora.
If
What does that mean to their mental health, to their resiliency, to their mood, to their like all these other factors, right?
Well, you've probably seen the studies that there's a lot of evidence that what's happening in your gut microbiome has impacts on your mood and your brain and stuff like that.
Yeah.
It goes everywhere. But
Yeah.
if I got this right, there's more DNA in us that's not us. Like, I don't think most people can grasp what that means or what we should do about that. But like, that's a daunting sort of thing to our sense of personhood. Like,
It is, and not to wax too philosophical on this, but it actually draws such an interesting parallel to a lot of the kind of the principles around kind of this idea of unity between like human and
Mhm.
environment, and the kind of how the ego protects our idea of self in the interest of being able to allow us to be productive in society, but how it's just a poor representation of reality where we're really just this construct that's no different from the desk or the soil outside, right?
Good. Well, that leads me to something else I worry a lot about, like so microplastics.
Yep.
So, as you probably have read, there are microplastics everywhere, every part of our body, every part of the environment, the most pristine areas of the world, the bottom of the ocean. And we do not have the slightest clue what they're doing to us. And I cannot but think that they are having very adverse effects on us. And I'm not sure that our healthcare system, our theories of medicine are at all capable of doing that. And we're certainly not stopping producing the plastics. So, like, so I was kidding with somebody about climate change. And like, climate change is going to kill us in 60 years. Like, oh, don't worry. The microplastics will kill us long before that. And I think that I fear that could be true.
Yeah, my wife said something funny. She's like, "Oh, don't worry about the microplastics. They'll find a medication that resolves them, or there'll be some type of new therapeutic modality worth $1 trillion that's that'll definitely involve giving people medications to deal with microplastics." But and that actually brings up to a point that I wanted to ask you, especially given your deep knowledge around health systems and health plans and PBMs in the states. But the other 8,000-pound gorilla out there right now, other than AI, is really GLP-1 RAs and the crazy impact that they're having on U.S. healthcare and healthcare in the world. I wanted to get your thoughts because you often hear this. There's been lots of debates happening right now, which I'm sure you're following, regarding cost of medications like Ozempic and Wegovy, and whether pharmaceutical companies are effectively just raking in on crazy profits. I recently listened to a podcast with the CEO of Eli Lilly, who mentioned that, well, more than 2/3 of those costs go to the system, to like PBMs and other players. And is that true for somebody who's, less familiar with US healthcare? Can
Well,
that even be proven? Like, what
on,
are your thoughts on
so when Congress passed the bills about regulating prescription drug prices, if you were looking at the drug companies' stock prices, they did not go down.
no?
So, no, I think they're doing quite fine. And this whole thing about well, if you cut our prices, R&D is going to go down. Like, more of your money goes to advertising than it does to R&D. So don't tell me that. So,
Yeah.
it's again, we don't know how to pay for innovation because we don't know what works for the most part. The interesting thing about the weight loss drugs is that, and I'm sure you are more well read on this than I am, but they are having surprising side effects. Other people's other conditions are getting better because they're losing the weight, which just goes to like, if we were just in better health in one area, we're in better health in a lot of areas. So there's something there. Should they charging $1 million a dose? No, probably not. But how do you brush that? PBMs, though, I would agree. PBMs, I don't really understand why they're PBMs. I mean, I worked in the industry. There's nothing like PBMs anywhere else in the delivery system. So why in that system?
Yeah. And for the uninitiated, can you briefly explain what PBMs are?
PBMs are prescription benefit managers. They're intermediaries between the drug companies and the insurers. They negotiate prices between the insurers, the pharmacies, and the drug companies. And I do actually have a little background on that. So when I started working in health insurance, most plans didn't have prescription drug coverage. It was part of the major medical benefits. So it just got thrown in stuff. You paid your deductible co-insurance with all your bills. But there was a card service out of Arizona called PCS that actually back in the 1960s, it started. You had a card and it connected the pharmacy with the insurer in real time and could do your drugs. And people are like, whoa, let's do that. And what is amazing, like, well, why didn't the rest of the insurance industry do that as well? That for 30 years, it was only a prescription card that could be read electronically real time. So that's really how the PBMs got their entree, and they became this juggernaut that then they started negotiating on everybody's part and then raking off these huge prices. And there's rebates between the insurers and the drug companies. And nobody really knows what the prices are of drugs or whatever. And I have Medicare Part D, and I don't understand the coverage because I worked in insurance all my life, and I literally do not understand my coverage structure. I got all these different networks and all these different tiers and, the pricing. It doesn't make any sense. I mean, the whole thing needs to be blown up and redesigned because there's too many people making too much money and it's too confusing to the consumers. And again, it's not to the consumer benefit.
Yeah. Yeah. No, so that's, and that's a challenge when the system is oriented to maximize profit, right? And it's really challenging because it does seem almost like outlandish to suggest that changes should be made that are in the interest of the patient because it's just so far removed from the functioning, as you mentioned, of this beast that's existing for the sake of existing for itself, right?
Well, like the FDA has really not been very helpful. So like in both drugs and medical devices, the drug companies make minor modifications to a drug to keep extending the patent. So that's why insulin has remained insulin, inhalers. They remain remarkably expensive for so long, even there's very, very little basic changes made to them. The drug companies, the medical device companies can basically avoid new testing, new verification of efficacy by just doing what they call minor modifications. So like the whole system of how do we regulate drugs and medical devices and make sure that they work and that if you're introducing a new one, it's actually more cost effective than the old one. I don't believe they're by law. I don't think they're allowed to do efficacy, cost benefit. So like that seems like a strange thing to prohibit, and you can only assume that they did that because the lobbyists for the drug companies and the medical device companies were more successful at influencing Congress than the patients were, which is always true.
Yeah.
We really got to get our hands around how we regulate these things in terms of, is it safe? Is it effective? Is it cost effective? And we mouth the words that we want it to be, but then we don't actually put our money where our mouth is.
And I think there's going to be an understandable tension over the course of continued tension over the course of the next 10 plus years as AI has the ability to democratize intelligence to a certain extent, and arguably people may become more aware, better be able to understand how things are being withheld from them or what could be optimized for them. While on the other hand, as you mentioned before, a lot of these tools could be used to just kind of keep the gloat as well, right? To kind of keep that gap and keep things moving. So I do feel like there's going to be increasing friction in that sense as well.
Well,
Especially if people have the ability to kind of hack their way into solutions, and they have knowledge and intelligence to be able to, potentially, at least optimistically, to be able to get more themselves as a result of knowledge and wayfinding potentially.
well, there's a great story here that you probably know the details more than I. But many years ago, I think this engineer's daughter was a diabetic,
Yeah.
and he was frustrated. So he built, his own diabetes insulin pump or whatever, and much cheaper. It's like there's a lot that can be done in a world of AI and 3D printing.
Yeah.
There's a lot of stuff that we're doing that can be done in your house by you. And like, why shouldn't we enable that? Well, we don't do it because a lot of people's turf would get stepped on. Like,
Yeah.
well, again, who are we trying to benefit here? Is this really about the health of the patient, or is it about the profits of the
Yeah.
existing players? Like, I think we know the answer in the existing healthcare system. Let's hope that's not an ironclad model.
Yeah. Yeah. Yeah, so it's a fascinating conversation. I feel like we could obviously keep peeling the layers here, but I'm cognizant of time. One thing I did want to ask was kind of what's next for you? What are you continuing to think about? I know obviously right now you're fortunately continuing to write, which is great for the rest of us, but what else is on the docket?
Oh, I'm not very ambitious these days. I'm happy if I can just keep writing.
Yeah.
As every week I tell my wife, "Oh, I don't know. I don't have a slightest idea about what I'm going to write about this week." And she's like, "You always say that, but you always come up with something." So
Yeah.
one of these days, I'm not going to think of any ideas to write about, and that'll be sad. But hopefully, I'll keep finding things that intrigue me and inspire me.
Well, hopefully for the rest of us, you continue to do that as well.
I appreciate that.
Thank, thank you so much, Kim. Really, really enjoyed this conversation.
Me too.